From 2001 to 2018, the price of insulin increased by about 11% every single year. And right now, the medication costs Americans more than $48 billion every year before discounts and rebates. But as the average cost of insulin continues to creep up, one state is working to cut that price down. And joining us now to discuss California's push to lower the cost of insulin is Daniel Tomaszewski. He is an associate professor of pharmaceutical and health economics at USC, one of my alma maters. Fight on. Thank you so much for being here tonight.
Thanks for having me.
You know, this is not the first effort to try and rein in high drug prices, including specifically insulin. So can you tell us what makes this plan different?
You know, one of the things that's different about this effort this time around is the fact that we are seeing this both efforts on the state level in California as well as some nonprofit manufacturers try to get into this mix to try and change the pricing dynamics that we see that related to insulins. To date, we've relied on traditional pharmaceutical manufacturers who use some of the traditional pricing metrics. And because of that, insulin continues to be treated like a brand name medication, and that's where you're seeing these increased prices year after year. If you take a look at overall net prices are actually holding pretty steady on insulins, but that's after a lot of discounts take place on the back end through pharmacy benefit managers and otherwise. These new concepts and new ideas that are coming out are tackling the list price. So the actual list price or cash price for insulin, as opposed to being reliant on PBMs offering discounts that are available through manufacturers.
And there seem to be a lot of unanswered questions still in this plan. When the insulin would be available, how much it would cost, could it be available for people living in other states other than California? When do you expect we could learn any of those details?
Those are a lot of details that there are very complicated pieces that come with it that make it challenging to answer. Questions like, does the state of California plan to partner with a contract manufacturer that maybe already has some operations up and running in this space that they would be piggybacking off of? Are they looking to work with some of these nonprofit manufacturers that are already got a head start on the clinical trials piece and really starting to get the data needed to submit for an FDA approval? That's the big piece. With these insulins, they're considered a biologic agent, which means they need to go through clinical trials to get FDA approval, which in best case scenario, you're looking at something maybe like a 2024 launch if California hasn't started that process yet. And then outside the state of California, that's another question that isn't answered. Are we strictly targeting our California residents, or is this a push to get the state of California into producing enough insulin for surrounding areas? We don't know those details yet. That's yet to be discussed.
And sorry to jump in there earlier, but this can't come early enough for so many Americans. Other countries seem to have figured this out. Insulin, we know so many people need it and they need it regularly. Why is it such a different picture here in the United States? Why is it such an issue?
That is a very complicated question that we could spend a lot of time discussing. How we pay for drugs in the United States is very different than European countries and many global global aspects, in the sense that we don't have direct negotiation of pricing on drug pricing from government entities here, which means we rely on intermediaries to provide those efforts for us, which means those discounts come in forms of manufacturer rebates. They pay their way through pharmacy benefit managers. We see list prices continuing to climb because the more we climb our list price, the higher the discount we can offer as a manufacturer. And those are the type of incentives that exist in the United States. If we can provide a bigger discount off of a list price, oftentimes we see insurance companies and PBMs prefer our product. So if the option is between listing a drug at $100 with no discount or listing it at $300 with a 50% discount, unfortunately, the way that the system is set up here in the United States, oftentimes those decision makers may prefer the $300 list price and so that they can obtain those discounts on the back end.
Daniel, that is wild to me, but I know it's a complex issue and we appreciate you jumping in there and trying to make it a little more understandable. Daniel Tomaszewski, thank you so much for your time tonight.
Happy to jump on. Thank you.
Thank you for watching. Go to newsnationnow.com to find NewsNation on your television provider. And don't forget to click the red subscribe button below to get more of NewsNation's fact-driven, unbiased coverage.